And on Good evening, everyone. On behalf of PHO chapter, I welcome all of you for our monthly national teaching program, the online teaching program. And today, Shruti and Vinay have helped me put across this program, which is mainly themed around hemophilia, a very important subject for all pediatric hematology oncology colleagues. And very diverse topics and very interesting program, and I hope you all will be benefited with that. So, welcome all of you, and Shruti and Vinay, please take it forward.
Good evening, everyone. I would like to welcome all of you to the National Training Program on behalf of myself and Vinay. And today our topic is management of hemophilia from classics to blockbuster. The idea behind choosing this topic for April month was, as all of you know, it's the World Hemophilia Day celebrated on April 17th. So we wanted to raise awareness and, talk about a topic which is not dealt in every hospital. So we thought it will be a good learning session, especially for students who do not have exposure to hemophilia management in their centers. So why classics to blockbusters is because we have factor therapies which are classic and change the management of hemophilia. But on the other hand, we have these newer drugs which are the blockbusters now, and they have changed the way we look at hemophilia and prophylaxis in hemophilia. So let's listen from our experts, and for that I will like to hand over to Vinay to take the proceedings further. Thank you.
So welcome all, as already Dr. Manas and Dr. Shruti have introduced. So today we hope we have an exciting session on hemophilia. To start the session, let's welcome Dr. Bipin Kulkarni. He's the head of head of Department of Hemostasis and Thrombosis at NIH Bombay. So he would take us through the laboratory diagnosis, the nitty-gritty of hemophilia diagnosis, and right from basics till diagnosing a child who is having inhibitors and how to do diagnostic tests when they are on certain newer drugs. So welcome, Bipin sir. The stage is yours for the next 10 minutes. Please help us out with the lab diagnosis.
Yes. So first of all, thank you very much. Good evening to all, and thank you very much for this opportunity. Am I audible to all?
Yes, sir.
Hello?
Yes, sir, you are audible.
Yeah. So thank you very much, and I'll just share my slide. Are my slides visible?
Yes, sir.
Oh.
It's not in the slideshow mode.
Yes, I'm putting. So,
yes.
And are they moving?
Yes, sir.
Okay, great. So in the next 10 minutes or so, I would like to discuss these topics. So the topic given to me was laboratory testing in hemophilia and the inhibitor testing. So in these 10 minutes, we'll see the clinical approach to a bleeding patient who should be tested, then the laboratory strategy for investigating a new bleeding patient, and then we'll look into the inhibitor screening and quantification. And then with the newer drugs, the extended half-life factors and what are the recommendations on emicizumab. And if time permits, I have some 4-5 cases. We'll look into that only if time permits. So talking about hemostasis investigation, you cannot ignore starting from the history physical exam and then the initial tests like the CBC, peripheral smear, then the screening coagulation before even we start deciding on what special investigations are required. So we need to start with these basics before jumping on to doing any specialized testing. For the clinicians, it is important to first check whether the bleeding is significant. So the ISTH BAC score will be useful here. Then to decipher whether it is a local or a systemic bleeding versus platelet or coagulation disorder, and the history will tell you whether it is inherited or acquired type of bleeding. And for the laboratory, it is best practice to have a complete detailed pro forma with pedigree, family history taken, the history of transfusions, consanguinity, everything before you take the blood sample for investigation. So for a new patient who is not diagnosed and he's a bleeder, so always we know that the primary and secondary hemostasis always go hand in hand. So we have to start with both parallelly. So what we do is we do the screening coagulation, PT, APDT, PT, fibrinogen, and on the other hand, we also do the platelet function testing, the platelet aggregation testing on an aggregometer with agonists like ADP, ristocetin, and collagen. So on screening coagulation, if you find one of the tests prolonged, like if you say APDT is prolonged, since we are talking about hemophilia, then the first thing you do is you do a 1:1 mixing of the APDT and check whether you are getting a correction or full correction or a partial correction or no correction. And so mixing might give you a normalization or no correction or partial correction. But in any which way, since the patient is a bleeder, you carry on with the factor assays as well. So most common is the one-stage factor assays which are done. So you do a factor 8 followed by 9, 11, and 12, which is based on the commonality, with factor 8 being the most commonly found, followed by 9. Of course, if there is a family history of a certain factor deficiency, you end up doing that factor level first. Uh, in the mixing, you may get inhibitor positive, and if there is no correction on immediate mixing, you also have to rule out lupus anticoagulant by doing a LA1, LA2 DRBVT test. So at the end of it, you might land up getting a clotting factor deficiency with or without factor 8 inhibitor, with or without lupus anticoagulant. And of course, on the other side, you are also ruling out the von Willebrand. So if ristocetin agglutination is abnormal, then you also do the von Willebrand antigen along with factor 8 deficiency. So once you have diagnosed the hemophilia, he will either be a severe, mild, or moderate case. So as we know, 30% of these severe hemophilics, they are prone to develop inhibitors. Now these inhibitors may be high responding, maybe which is more than 5 Bethesda unit per ml, or low responders with less than 5 Bethesda unit per ml. So they run the risk of inhibitors. So what are these? So inhibitors are nothing but IgG alloantibody, which are developed to the exogenous clotting factor 8 or 9, which is infused to the patient, and they neutralize these factors and make them useless, and the patient bleeds. So these inhibitors can be measured, they can be screened first and then quantitated. So when should inhibitors be tested once you have hemophilics? So these are the recommendations. So in children, once every 5 exposure days till the 20 exposure days, every 10 exposure days between 21 and 75, at least 2 times per year until 150 exposure days. Or if the child is intensively treated, you test for inhibitors. Or if you are switching factor concentrates, you do inhibitors. Now in adults with more than 150 exposure days, you must do inhibitors and do a periodic review every 6 monthly to yearly for inhibitors. And if a patient is previously responsive to inhibitors and now he is failing to respond, you should definitely do inhibitors. Inhibitors should be done prior to surgery, or if the recovery of the assay is not as expected, or if the clinical response to treatment is not up to the mark post-surgery. So in all these scenarios, you have to do inhibitors. So the inhibitor testing is basically an extension of the APDT assay. So in APDT, we measure the normal control along with the patient. So a third reaction you have to put, that is 1:1 mix of the both and do an APDT of the 3. Then you incubate these 3 tubes at 37 degrees centigrade, and after 1 hour, you do an APDT of all these 3 plus 1 more, which is take the NPP and the patient which are separately incubating, mix them, and you see the difference between your third and fourth reaction, which is the mixture versus the one which is mixed outside and not the one which is mixed together and incubated. So you see the difference between these two after 1 hour and 2 hours. And if you get a difference of 5 seconds or more, which is increasing after the first hour to the second hour, then it indicates that the inhibitor is positive. Now, this inhibitor test screening has certain limitations, and hence it is not recommended in the guidelines, but still it can be used as a useful tool. Now, the limitation is that the low titer inhibitors up to 2 Bethesda units can be missed by the screening test. But we can keep certain things in mind and still use it as an important tool for screening for inhibitors. So always correlate with the clinical recovery of the patient. Correlate with the factor recovery assay in the laboratory. How much correction is given? Are you getting that much correction in the laboratory? That correlation has to be done. Uh, we have to perform the Nijmegen Bethesda even if the screening is negative, but the clinical or the factor recovery is poor. So if the patient is a bleeder, even if screening, as we know that the screening can miss low titer inhibitors, so Nijmegen Bethesda should be done if the recovery is not up to the mark. I will not go into the technical details of the Bethesda assay for quantification, but only thing I need to say here is that uh, a pre-incubation stage, like if you want to not waste your time or waiting for the washout period, you incubate the plasma at 56 degrees for 30 minutes, which will destroy all the remaining factor VIII present in the plasma, and even the low titer of inhibitors will be available for the assay, and you can pick the inhibitors very reliably. Now, this assay can be made more sensitive by certain modifications which we call as the Nijmegen modifications. So what they do here is that these are technical terms actually. So uh, in the first stage, what you are seeing is the serial dilution of the plasma using the buffer. So instead of buffer, they use the factor VIII deficient plasma. And in the next stage, we give a uniform hemostatic environment by adding normal pool plasma to all these dilutions individually. So in the Nijmegen modification, this NPP or normal pool plasma is buffered to a pH of 7.4 to make the assay more sensitive. And then it can be quantitated and the assay, the results are given in Bethesda unit per ml using this graph. Now, once in a while, you may always encounter an inhibitor which is immediately acting, meaning we know that factor VIII inhibitor is time and temperature dependent. So immediate mixing may not give you the presence or the difference in time. But every once in a while, you may see that the immediate mixing is not correcting. So this could be an LA or it could be an immediate acting inhibitor. So how do you go about in such cases? So if it's a new patient, you have done the PT APDT is deranged, there is no immediate correction. On the other hand, you always rule out von Willebrand. So if that is not the case, now you come back here, you do a factor VIII level. Uh, since there is no immediate correction, you are also doing a DRVVT a day. So factor VIII, you are getting less than 1. It's a severe case of factor VIII deficiency. You do a Bethesda assay, which may be positive. LA may or may not be positive. So if it's a LA negative with Bethesda assay positive, then you have a factor VIII deficiency with immediate acting inhibitor. You can do a further classification of it or further testing using ELISA or chromogenic assay if it is available to you. But one thing is for sure that now you're looking at a immediate acting factor VIII inhibitor. Now, if LA is having very high positivity, then it is best practice to also do at least a factor IX assay, because these are APDT based one stage assays which can the antiphospholipid antibody can mop up the phospholipids in the APDT reagent and falsely give a prolongation of factor IX assay as well. So what the best thing to do is you just do higher serial dilutions of the plasma, which will dilute out the LA. And then at higher dilutions, you will get normalization of the other factor deficiencies which are non-specifically you are getting because of LA. So the LA-induced non-specific multiple factor deficiencies in a genuine case of hemophilia A, you can distinguish doing this exercise. Now, these are the various combinations you can see if you have LA and immediate acting inhibitors in congenital hemophilia A. So, what the picture you will see if it's only LA positive, or if it's a combined LA and factor VIII, or if it is only factor VIII immediate acting inhibitor. These are the various combinations you will see. I'll not go into each and every point because of the time constraint, but these are the this is how you can pick up what kind of inhibitor you are dealing with. Now, since we are talking about one stage assay, it utilizes APDT. Now, APDT by itself has so many variabilities, and you have to keep that in mind. It can influence your factor assay performance by the type of contact activator which is there in the ability reagent, whether it is silica based, ellagic acid based, or equivalent based. The factor deficient plasma that goes in the assay, whether it is sourced from the patient or a commercial source, the instrument on which we are doing the assays, whether it is mechanical or optical, because optical it will have effect if it's a hemolyzed or ecstatic plasma. The APDT reagent by itself has different sensitivities to different deficiencies, like particularly the mild deficiencies. Some of the reagents are not very sensitive. We have different sensitivities to lupus anticoagulants, which has to be kept in mind. The best thing is to use both. Uh, Best thing is to you have both high and low phospholipid containing reagents in the lab. For diagnosing bleeding disorders, use a high phospholipid containing reagent, and it can have different sensitivities to heparin. And one thing now to keep in mind is that the reagents can have differential sensitivities to extend the half-life factors, which are now commonly used. So if we compare the one-stage assay to chromogenic assay, now chromogenic assay being the gold standard as we know, because it has less variability and it can give more accuracy. Your factor 8 present in the patient plasma is the rate limiting step in that assay. Now, the most common one is one-stage assay. We can do it reliably, considering we have to keep certain things in mind which we have to be careful about, which is that is the phospholipid source and the concentration in the reagent, what activator is present in your reagent, as we discussed in the earlier slides, the factor 8 deficient plasma, what calibrators you are using as your normal control, whether it is for normal pool plasma made in-house or whether it is from a commercial source. Even if it is from a commercial source, you have to know what kind of factor level that source had, and the measurement technique, whether it's optical or mechanical. So if you control these variables, you can very well use a one-stage assay for all your practical purposes of factor assays and inhibitors. Now, these are the different these are the different extended half-life factors which are available, factor 8 and factor 9 in the market. So what the literature says is that various APDT reagents can have differential sensitivities to the extended half-life factors, and accordingly it can either underestimate the factor 8 level or overestimate the factor 8 level. And only if you use the right kind of reagent, then you can get a correct factor 8 level for a given extended half-life factor which is being used in the clinic. So it is the responsibility of the laboratory to have a dialogue with the clinic always, and to have this two-way communication as to what extended half-life factor a particular patient is taking before you send the patient to the lab for the assays. Now, this is what the World Federation of Hemophilia guidelines and other papers also say about the extended half-life factors. Now, in KEM Hospital, Epsilon was being given to some patients. So we had that opportunity to test whether our assays are working well and which reagent is working best for the Epsilon that is being given. So when we looked into the literature, it says that the one-stage assay can underestimate the factor 8 level by to a degree of 45%. And if you have to give out the value, you have to apply a conversion ratio and multiply the factor by 2, and then give the level. So we thought of doing an exercise in-house. So what we did was we used the like versus like principle. So what we did was we took a commercial factor 8 deficient plasma and spiked it with the EHL that was being used, and we made the standards out of that. And then we tested the various APDT reagents that we had, and then we identified one of the reagents which was giving perfect results with all the dilutions which we compared against the chromogenic assay. And then in the real life situation, we took the patient's plasma who had who had received the corrections of factor 8, and then we measured using the same method, and we found that this particular reagent, which has silica activator, Siniclot, it worked best for the Epsilon that was being used in the lab. So what this exercise tells is that selecting the appropriate APDT reagent and the EHL specific calibrators for accurate monitoring is very essential. And if you're doing this exercise first time, it's always best practice to compare it against the chromogenic assay. And this can be applied to any EHL factor which is being used in any clinical setup. The lab has to just make the calibrator accordingly and test which of the APDT reagents is working best. Coming to emicizumab, we know that this is a humanized bispecific antibody that recognizes factor 9A and factor 10 and brings them together. But if you are using this, this is a boon to the patients and the clinicians, but it is a nightmare for the laboratory, both EHL as well as the emicizumab nowadays, because it poses a lot of different challenges. So if the patient is receiving emicizumab, the APDT is considerably shortened by emicizumab. It affects all the assays which are based on APDT and also the chromogenic assays which have human reagents, human factor 9 and factor 10. So how do we measure the factor 8 activity? So the World Federation of Hemophilia guidelines, it recommends using bovine reagents, bovine factor 10 containing chromogenic assay. So here the APDT, since it shortens, on emicizumab, you cannot use it for monitoring. Factor 8 assay is the one-stage clotting assay, will show falsely elevated factor 8 level because of the high affinity of emicizumab, and this cannot be used to monitor. The chromogenic assay with human reagents also will falsely elevate factor 8. Only the bovine reagent containing chromogenic assay can give accurate factor 8 level activity. If you have to measure the factor 8 inhibitor assays, again, the Bethesda or the one-stage clotting assay cannot be used. It will give false negative. So even if the inhibitor is positive, it will give negative here. Only the chromogenic Bethesda, which is again bovine reagents, will give the accurate reason. So what is important here is that always keep the laboratory informed about what the patient is taking, so that the laboratory can come back to you with appropriate investigations and the right level. Always prefer chromogenic assay with bovine reagents if the clinic is using emicizumab, and always practice caution while interpreting all the assays, particularly the EHLs and the emicizumab as based assays. So this is what the World Federation of Hemophilia guidelines say about emicizumab testing. So if you want to measure the emicizumab levels, then a modified one-stage assay with specific emicizumab calibrator should be used. So if you want to determine the factor 8 activity, then the chromogenic factor 8 assay containing bovine factor 10 should be used. If you want to measure the factor 8 inhibitor level when the patient has received emicizumab, chromogenic factor 8 assay containing bovine factor 10. Now, if you are suspecting neutralizing anti-emicizumab antibody, which is very, very, very rare, but we have some cases. So if you want to do that, again, a modified one-stage assay with the emicizumab specific calibrator should be used. This is what the World Federation guidelines say. Now, I have some cases, some 4 or 5 cases. I will discuss them only if the time permits. So,
Dr. Bipin, I think we'll go ahead with Dr. Neeta's talk, and if at the end the time permits, we'll come back. I'm sorry, we are actually very excited, but in the interest of time, we will have to.
Sure. That's why I have split this into 2. So cases I can take up later if the time permits. Thank you very much.
So actually, Dr. Bipin has highlighted that, how we all need to keep up ourselves with the testing, and we need to sit down with our lab colleagues and discuss, what is the therapy that the child is getting, and modify the investigations as per the child's treatment. So with that, I would like to next call upon Dr. Neeta Radhakrishnan. Dr. Neeta is additional professor and head Department of Pediatric Hematology Oncology at PGICH Noida, and I don't think she needs an introduction to this audience. So Neeta, over to you, and she'll be talking about evolution of management of hemophilia over the years. Thank you, Neeta.
Can you hear me? Is my audio clear?
Yes, absolutely.
Thank you, Shruti. Thank you, Dr. Vinay, and thank you to the PHO chapter for this opportunity. A very concise discussion on the laboratory, Dr. Bipin. And after that, I'll be discussing the management of hemophilia. And it's a very vast topic to be brought it down to around 40 minutes. So I'll try and skip things which are probably out there. You can just go look, open the guideline and have a read. Whereas things which we need to know, things which are more practical, I'll try and highlight that. So this is from the annual global survey of 2023. There's a World Federation of Hemophilia that brings out this document every year. So these are data which is collected from the national NMOs, that is the national member organizations of every country. And as of now, this is the number of patients that we have globally, and of which around 2 lakh patients are suffering from hemophilia. In India, the NMO, or the National Member Organization, is Hemophilia Federation of India. So around 22,000 hemophilia A patients are there registered in the country, and around 3,600 hemophilia B. So hemophilia A and B are X-linked disorders, as you know. 1/3 of patients have a new mutation, and the others are inherited from the mother's side. So you would look as residents, you would ask for the history on the maternal side. It's usually mother's brother, or probably the mother's father himself would be a hemophilic. And so there are conditions where the mother would be an obligate carrier. If you have had 2 children with hemophilia, if you have a child and a brother with hemophilia, if you have the bond to a hemophilic man with hemophilia, so these are conditions where you would be an obligate carrier, but otherwise it could be a new mutation in the mother as well. So males are affected, females are carrier. This has been the classical teaching, but now there's a change in the terminology. So if you look up, there is something called women and girls with hemophilia now. So that is the approved terminology now to discuss carrier women. So they are no longer called carrier. Carrier is a laboratory terminology now. For a clinical terminology would be a woman or a girl with hemophilia. And like we would discuss hemophilia. So hemophilia, a boy with hemophilia, if the factor level is less than 1%, it is called severe. 1 to 5% in the body, it is moderate, and more than 5% it is mild. Similarly, for a woman and girl, there is a new classification, which is again similar. So less than 1 to 5, and 5 to 40% are the cutoffs there. So here again, they have noticed that even girls can bleed. Why I'm highlighting this so much is that because, like Shruti mentioned, this coming World Hemophilia Day, the theme this time is women can bleed. So they are highlighting all the bleeding issues in women, especially rare bleeding disorders, as well as bleeding in carrier females or women or girls with hemophilia. So this is how we classify hemophilia. Now, between hemophilia A and B, there is an age-old discussion as to whether hemophilia B is as severe as hemophilia A or not. So there are different sets of people have reported that bleeding pattern is usually similar. So usually we also observe the joint and muscle bleeds is almost similar. But overall, if you look at numbers of patients with severe hemophilia who come in with multiple episodes of bleed or their annualized bleed rates, it's slightly lower in a hemophilia B compared to hemophilia A. But then there is Indian data refuting this also, saying that it's exactly the same. We don't have any long-term prospective data from our country to show this, but from US, they have reported that of the patients who are receiving prophylaxis, probably only half of hemophilia B receives as much prophylaxis as A, probably because they are less bleeding. The numbers of orthopedic surgeries are less in hemophilia B, and ultrasounds the base joint scores also are less. The plausible explanation for this is, I'll come to this picture again before I go there. So the hemophilia B, the protein is a smaller molecule, and it has an extravascular spread, which is whereas in the hemophilia A, the molecule, the protein is larger and it stays in the intravascular space only. So your tissue bleeding, probably it is hypothesized that because of this extravascular distribution of factor 9, the bleeding is much probably lesser at the tissue level. It can distribute to the extravascular space and it can bind to the collagen 4. That is one explanation. The other explanation is probably that there are other mutations that can spontaneously improve over time. So one classical example is hemophilia B laden, which has been described where because of a promoter mutation, by the time the patient is an adolescent, the factor 9 levels actually start to improve. So the disease phenotype actually reduces with increasing age. So these are certain explanations why hemophilia B would probably be a little milder than A. And then again, when you consider the mutations, so when you consider the reasons for hemophilia A versus B, there are larger mutations in hemophilia A, whereas there are smaller mutations like missense mutations are more common in hemophilia B. And this again, when you have a large mutation, chances of having inhibitors, because you've never had exposure to factor at all, your larger mutations, patients who are more severe disease have more chance of inhibitor generation. And this is again why in hemophilia A, we see inhibitors, like just Dr. Vipin just mentioned that up to 30% patients have inhibitors, whereas in B, you would find inhibitors up to 3 to 5%. So whatever said and done, whether it is hemophilia A, B, or von Willebrand disease, which is again a condition which goes in parallel because there is reduction of factor VIII level there as well. So these children present usually with bruises, a lot of bruising tendency when they start walking, when you hold them very tightly, when they fall off. So these are classical common presentations. They present with joint bleeds. Again, majority of bleeds are into the musculoskeletal system. So that was what's going to repeated bleeds are what is going to make them disabled. Children present with bleeds post-trauma. So head injury is a common presentation and leading to death. Post-cannulation, they can. So blinded procedures in these children are very dangerous. So especially chubby children who are getting picked up at probably at that age around 6 months to 1 year, when this bruising is happening, when they're coming for a testing. If we attempt cannulation or attempt sampling from these kind of cubital area where you're not actually seeing the vein and poking, it can end up with very bad contractures as well. Children can present with deep as an oral bleed. So spontaneous oral gum bleeding would not be seen in a coagulation disorder per se. You could say it in von Willebrand disease because there is a platelet issue as well there. Whereas in patients with hemophilia A and B, you would not see gum bleeding to that extent or epistaxis to that extent, but you can see tongue bites. So children running around, you can see tongue bites. After a tooth fall, there would be bleeds that are very common. You could have psoas bleeding, which is a muscle bleed, which is very disabling. And then you could have renal bleeding or intracranial bleeding, which are in deep bleeds, which are often life-threatening. So what is the classical natural history of hemophilia? Why I say in India is because their access to treatment is probably a little lesser than what is there in high-income countries. So typically when a child is born, only around, so in India currently, when we say 22,000 patients are there, that the estimate is that we are picking up only around 20% of the actual patients who are there, because many children are not picked up. So 1/5 of diagnosis only is happening. The rest are not even diagnosed. The rest died before a diagnosis. And time to diagnosis is also extremely delayed in India. So we did a recent audit of the centers in the country, and we saw that a lot of patients are getting picked up after 2 to 5 years of age as well, which is rare. Whereas in Western countries, it would be most of them know already, or most of them are picked up before 6 months of age. In early childhood, they come with repeated bleeds into the joint, and then a time to a target joint. Repeated bleeds into a joint cause what is called a target joint, and that target joint and joint destruction happens earlier in the country. In countries which have very poor access to the product. By adolescence, they generally have multiple target joints, and because of this, then it is just a spiraling downwards because they don't get to attend school. They don't have regular attendance. Their quality of life suffers because of that, and there is high risk of mortality as well. So this is what we used to see, and like is mentioned in the title, so that this is something which is becoming a matter of the past now because of access to blockbuster drugs. It's becoming better as every year it's getting better. So why are joints so important in hemophilia? So I would quote a physiatrist, Dr. Pamela Narayan. So she mentioned once that hemophilia starts as a disease of a hematologist, but ends up as a disease of a MSK specialist. MSK is a musculoskeletal specialist. So it's very true that ultimately when you manage patients with hemophilia, you need to know a little bit of what is happening in the joint and how to rehabilitate these patients. So repeated joint bleeds into the joint will cause destruction, will cause synovial hypertrophy, and the cartilage starts getting destroyed, and ultimately the bone is destroyed as well, causing permanent joint damage, and many patients even require joint replacements as well. So earlier, the treatment used to be with only plasma. Then they started taking out what is necessary from the plasma, not necessarily giving the entire plasma. So it is usually cryoprecipitate for factor VIII and cryosupernatant for factor IX. And then there was a huge epidemic of, as in a blood scandal, which you could again read up, which will see that there were a lot of patients who were affected by HIV. After that, then came this concept called viral safe plasma. And from there, we have had products which are recombinant, And from there, now we have products which are extended half-life, like Dr. Bipin mentioned, non-factor replacement. And now there is a possibility of cure also in hemophilia through gene therapy. So a lot of people are involved in the care of a hemophilia. It's not just a person, a hematologist who is managing. There are a lot important team members would be a physiotherapist or a physiatrist. A rehabilitation specialist is very, very important. Nurse is very important in the treatment. And like in any chronic disease, a psychosocial team is as well important. So this is the bleeding pattern. So next few slides, I'm going to go very quickly because this is there from World Federation of Hemophilia 2020 guidelines. You can just look it up. So usual pattern of bleed, most common bleeding pattern, like I said, 80% bleeds are going to be in the joints and muscles. So that is where all the damage is going to happen. So we have to be very careful and treat and try to prevent the bleeds into the joint and muscle. So these are how you term these bleeds: serious bleeds and life-threatening bleeds. Joint bleeds, the common sites of bleeds are the ankle, the knee, and then probably the elbow, shoulder, hip, etc. The joint bleeds, again, when the bleed starts. So many patients would come to you before even the joint becomes tender, because they know that there is a tingling that's happening in the joint and they know that the bleed is going to happen. So that is called an aura. And these are the different types of bleeds that happen. So now how do you treat these factors? So there are different types of treatment. What WFH mentions, all the different types. So generally, treatment is either you treat a bleed or you prevent a bleed. So when you treat a bleed, this is the dosing that you use. So based on what you have and where you're working, you decide the dose. So if you have hemophilia A, and if you're having a joint bleeds, you generally target increasing the peak factor level to up to 20%. If you have no restriction, if you are in a very resource plentiful situation, then you could increase the level to 40 to 60%. The levels are similar in A or B, but only difference is that in A, when you give the dose, you have to you can give 50% of what you calculate, because every unit you give increases the factor level by 2%, whereas in B, you give the entire same number as well. So based on where the bleed is, you can calculate according to it. Many bleeds which are difficult, like even in the MSK bleed, an Iliopsoas bleed is very difficult because you have neurovascular injury associated. So then there is something called an initial treatment and a maintenance treatment. You have to maintain treatment for few more days and sometimes few more weeks. So you continue a prophylaxis few more weeks after that. An intracranial bleed, again, you treat initially, you raise the level to up to 80%, then you maintain the level to up to around 40% for the next 2 to 3 weeks. Throat bleeds, gastrointestinal bleeds, like based on the severity, the level is decided. And in surgery, if you want to do a major surgery, again, it is 80% in a resource restrained settings, whereas in a resource plentiful setting, it would be 100%. And this is how you calculate the dose. Again, hemophilia A, the factor 8, it is administered 2 times a day, whereas 9, it is administered once a day. What are the products that are available with us? We generally have access to recombinant products. If recombinant factor is not available, then the option is plasma-derived. And plasma-derived factor, based on the type of purity of the product, very high purity, or intermediate purity is there. So because that's taken from FFPs which are discarded, as in FFPs which are not required by blood banks. So these companies would take that and then pool it and make it out of it. In Western countries, you can have plasma donors as well, where you can go test yourself. So that is more safe from that aspect, because you know who as in you have a regular pool of plasma donors for that. Now, intermediate purity has higher concentration of von Willebrand factor, because it's not purified only 8 separately. It is more of a homogeneous mixture of 8 and von Willebrand factor. So in our country, since we do not have access to recombinant von Willebrand factor, we use what is called intermediate purity factor 8 if you have a von Willebrand disease patient. Again, in a joint bleed, initial few days, you will have to restrict the mobility of that joint. And after 3 days, you start rehabilitation. Like by the second or third day, if your symptom hasn't improved, then you need to rule out inhibitors. Again, like Dr. Bipin said, if there is suboptimal improvement to factor 8 concentrate, definitely look out for inhibitors. Terminologies that you need to know again: RICE, PRICE, and POLIS. RICE is what they used to call earlier rest, ice, cold compression, and elevation. That is what you do to the joint to give a tamponade effect, and cryotherapy to reduce pain. And then they made it PRICE, and they added one more aspect of protecting the joint by splinting. And now what they call it is POLIS. POLIS means the O is for optimal loading. Optimal loading, by optimal loading, they mean that the patient should start load bearing or physiotherapy by the next 48 to 72 hours. Otherwise, the joint is at a risk of, there is a risk of atrophy of the muscle, of disuse atrophy if we do leave it alone. So this is about joint and muscle bleed. And iliopsoas bleeds, you advise strict bed rest for the first few days, and then slowly graded physiotherapy is advised. You need a very good MSK specialist to manage those kind of bleeds. Oral bleeds, in addition to factor, you give antifibrinolytic agents. CNS bleeds, like I said, factor first is the principle. Any bleed, any patient walking into emergency saying you have a headache or a trauma, just give factor first and then evaluate. Because by the time you schedule a CT, it might be too late. Antifibrinolytics we use in treatment at tranexamic and ACA, you know the doses. Desmopressin is another product which is used in patients with mild von Willebrand disease or hemophilia A. I think I'm getting calls to wind up this part of the talk. So I'll just quickly say annualized bleed rate is what a number that you need to know. It is the number of bleed, it's the projected number of bleeds a patient can have by looking at the weeks of data you have and then multiply it by 12. So now when you look at optimal therapy of hemophilia, the optimal therapy is actually to provide replacement therapy. And this is again from the World Federation of Hemophilia that you can have multiple doses of giving prophylaxis. You could give it as low dose, intermediate, or high dose prophylaxis. We generally start after the first joint bleed, before the onset of joint disease a joint disease. That is when you start. Now, clotting factor prophylaxis is there, and now there is non-factor replacement therapy as well. Now, what are the challenges? I think we have two cases pertaining to these challenges. So these challenges currently in management or complications of hemophilia would be hemophilic arthropathy, inhibitor development, and poor quality of life. So to counter this, you have new products like extended half-life products and non-factor replacement. When extended factor, you are extending the half-life by pegylation, Fc fusion, or albumin binding. These are three techniques to increase the half-life of the product. So now I'll request Dr. Sudipto to discuss a case where we have used extended half-life product and show how the response happen and how it is better when you compare it to a standard half-life product. Over to you, Sudipto.
So, Sudipto, we have two fellows, one Dr. Sudipto from Dr. Neeta's Center and Dr. Shreyasi from BJ Vatia. Along with that, we have a hemophilia nurse, Ms. Minakshi Dalia. She works as a hemophilia coordinator at CMC Ludhiana. So once you're discussing the cases, we'll get her opinion also, how important it is to have a coordinator nurse when we are looking after patients with hemophilia. Thank you, Sudipto. Please go on.
Good evening, faculty and delegates. So I would like to discuss this case. He was a 16 years old boy with severe hemophilia B, and he was on episodic treatment till 2019 with an annualized bleed rate of 6 to 8. In 2019 December, he was having a right psoas bleeding, and he was complaining of pain in the right thigh of 2 days duration, and also he was having limp, and there was paresthesia of the medial aspect of the right thigh. Next slide, please. So on examination, he was having right hip, which was flexed, and there was pain on extension, and swelling and tenderness was there in the right lumbar area. And so we had suspected a right psoas bleed, and we had started this patient on factor 9 replacement at 30% correction for 5 days. So after that, we had gone for an inhibitor testing, which was negative, and he was doing well. And so 3 months later, after this episode, in 2020 March, he was unable to extend the right hip and knee joint again, and there was a rebleed. And this patient was now started on secondary prophylaxis, and strict bed rest was advised. Regular follow-up was not feasible because of the COVID situation which was there. And so there was a teleconsult for physiotherapy, and pain and paresthesia persisted. And there was difficulty in walking. So he was not able to walk at that point of time. So this is the figure showing this is the MRI images on the left side. The MRI images are showing that the iliopsoas bleed, which is visible by the mark which is circled by the red. And iliopsoas is a muscle which is a combined muscle which originates from the vertebra and it inserts into the femur, and it crosses over the pelvic area, pelvis joint, pelvic bone, and it actually covers the neurovascular bundle. And so tingling and paresthesia sensations can occur at when there is iliopsoas bleed, and this is an important clinical sign. So as described in the photograph, so there was increased T2 signal intensity in the right iliac and the right pectineus muscle, and there was femoral neuropathy. Nerve conduction studies showed radiculopathy from L4 to S1, and electromyography showed the normal MUP but reduced recruitment in tibialis anterior. So this patient was then shifted to tertiary factor 9 prophylaxis, and initially he was on standard half-life factor 9 prophylaxis at 20 IU per kg twice a week from April to May 2020, and then this child was shifted to extended half-life recombinant factor 9 fusion protein alprolix at 40 IU per kg, which was given at an interval of 10 days to 14 days, that is 10 days to 2 weeks. So this was the situation, and this is the patient. So at November 2020, we are seeing that he's still having a limp while he's walking, which significantly improved from to January, and till August 2021, he was almost normal. So what were the learning points from this case? That in psoas bleed, neurological deficits could be prevented if we are careful enough about the paresthesias, and even if the nerve pulse is established, it can be improved with persistent efforts, and these are the advantages of having a long-acting product in prophylaxis. So these are the just shortly, these are the experiences in our center. So we are using Eloctate and Alprolix. Eloctate is a factor 8 with extended half-life. Alprolix is a factor 9 with extended half-life. We are using this from 2023, and usually we are using this in joint rehabilitation and in post-surgical prophylaxis, especially when children want to cover up from board exams or other competitive exams, we are using it, which are usually give. So, and this is for joint rehabilitation. This has been a very good product, and so, and these are the results which we can see that the annualized bleeding rate had decreased significantly from the pre extended half-life as compared to the post extended half-life factor 9 usage among these patients. And this is the hemophilia joint the score, which is also has improved significantly when we had used her. And this is a photograph of a pseudo tumor in a patient with hemophilia. And as we can see that this also had improved significantly after using extended half-life factor products. So this is the now is open for discussion.
Do you want me to stop share, Shruti, now?
That's fine, Neeta. I think I would like to call upon Shresi. Shresi, do you think you would have done anything differently in this case? Dr. Ritika can help can help her out in that.
Yeah, I think.
Hello.
Yeah, Shresi, would you like to say?
Yes, ma'am. So this patient, really considering that he had a chronic joint arthropathy, the patient with positive inhibitors this patient definitely would require immune tolerance induction. However, and the bypassing agent ideally in this situation would have been a recombinant factor 7 rather than a FIBA. But in the current scenario and looking at the cost effectiveness, obviously emicizumab and extended half-life factor is the best option rather than standard products.
Thank you, Shresi. I would like to call upon Meenakshi, the hemophilia nurse coordinator. Meenakshi, what do you think is the role of a nurse coordinator or a hemophilia coordinator in managing such patients, and how do you counsel them when they come back with a bleed, and how frequently do you do the joint scores and all?
Sorry, ma'am, I'm not able to hear your question. Your voice is very slow.
Meenakshi, can you hear me now?
Yes, I can.
Yeah. So, Meenakshi, if such a patient with joint bleed comes to the clinic, how do you manage such a patient? How do you counsel them, and how do you, work in collaboration with physiotherapy? So, would you like to comment on management of such patients?
So, yes, I'll explain the CMC protocol only. Whenever patient come to whenever patient had any bleed, they call us, and we have a hemophilia on call number with they have the hemophilia on call number with them. They call us and they ask us that we have bleed in that particular area. Then we check the availability of the factor if the factor is available, because most of the time the patient come from the farther places. So yes, we check the availability of the factor. Then if it is available, then we call the patient to our daycare center. And after assessing the joint, the swelling, the warmth, whatever, like the assessment, first of all, we do the assessment. And if we really feel that we should inform somebody, or we cannot assess alone this, then we call our resident to see whether but if it is a small bleeding or we can assess, then yes, then for all the joint bleed, we usually give 30%, and we have extended half-lives only. All the factor we have with us is with the extended half-life only. So we give according to the 30%. For the muscle bleed, we usually give 40. For all the muscle bleed, we give 40%. And after, we tell them that when we give next for 5 days, then we tell them once the pain will subside and the swelling will be come down, then they can come to the physiotherapy department, or can take ortho consult. Okay, and then they can plan with the physiotherapy. So we have a physiotherapist for especially for the hemophilia patients. So yes, we direct them to that particular person, that this person will come and with this bleed and all, and then they start with the physiotherapy and they inform us how it's going on.
Thank you, Meenakshi. So that's what we wanted to highlight, that it's important that there is a emergency number where the patients can contact, and there is a team, there's a nurse coordinator, there is a dedicated physiotherapist or a team of physiotherapists who looks after children with hemophilia only, so that optimal joint management can be done. So I think we are already running late, so I would ask Shresi to, continue with her case. Over to you, Shresi.
Yes, good evening, everyone. I'd like to begin my case. So we have a 1-year-old male child who was born of a non-consanguineous marriage, and he presented with on and off ecchymosis on his body for the last 4 months. Otherwise, he did not have any significant history of bleed, and neither did he have any history of bleeding earlier to that. And next slide, please. However, on a pedigree, we found that he had a maternal uncle who had history of prolonged bleeding after trauma and has on and off ecchymosis, however, never evaluated. Please, the next slide. On examination, he was a vitally stable child with only a few ecchymosis, and the joints were normal, no other bleeds whatsoever. Next slide, please. The initial investigations showed that he had a prolonged APTT, and a complete coagulation profile showed that he had less than 1% of factor VIII, thereby calling him a severe hemophilia A. Next slide, please. So this patient was started on low-dose prophylaxis with standard half-life factors and twice weekly. We monitored his inhibitor titers after every 5 exposures, and we found that they were initially negative. At 14 months, the child suffered a fall, and he came with a hemophilic arthropathy of his right knee. It was proven radiologically and clinically as well. Next slide, please. At this juncture, we gave the child immediate factor VIII replacement, and when we sent for the inhibitor studies, we found that this time his inhibitor levels were positive. Next slide, please. On the Bethesda assay with midway modification, we found that his inhibitor levels were 5 Bethesda units. The next slide, please. So for this management of the child, we implemented the police protocol, and along with that, Pranixa and analgesia was given to the child. For definitive therapy, we chose FEBA as a bypassing factor. Next slide, please. The FEBA we chose was given at 50 units per kg, 12 hourly for 3 days. We found that the patient improved and the joint swelling also decreased. However, we also had to tackle the inhibitor status. The next slide, please. So for the inhibitor status, we started the child with immune tolerance therapy since he was having a borderline between low to high levels. We gave him factor VIII at 50 units per kg thrice weekly, and we checked his titers every 4 weekly. When it became negative, we checked for factor VIII recovery. When we found that the recovery was more than 66%, we stopped the immune tolerance therapy and we started the child on a low dose factor VIII prophylaxis again. The next slide, please. And here is a graphical representation of the timeline where we found that gradually with the immune tolerance induction therapy, the inhibitor levels went down. However, even with 0 inhibitor levels, the factor recovery took another 4 weeks. We continued ITI till the factor recovery was adequate, and only then we restarted the child on low dose factors VIII prophylaxis. Meanwhile, the child had 2 episodes of joint bleed while on ITI, and both were treated with FEBA. Thank you, ma'am. This is all.
So thank you, Shresi. Shresi, would you like to comment upon the immune tolerance therapy, the indications, the inhibitor level, and just for the benefit of all the students, how do you go about giving immune tolerance therapy? If you can briefly summarize.
Yes, ma'am. So the idea behind immune tolerance therapy is to give a higher dose of the already given factor to the patient till we find an anamnestic response. The idea is to nullify the circulating antibodies which are there. So if it is a low titer inhibitor status, which is like if the Bethesda units are less than 5 units, we can try and continue our factor prophylaxis, albeit at a higher dosing. What we were initially giving, like twice weekly. This child was initially in 15 units. Maybe the child would have been given something like a 20 units or a 30 units twice weekly. If we find it is a higher inhibitor, more than 5 Bethesda units, then usually we try and give the immune tolerance induction, where we give a much higher dose of the previously given factor and for a prolonged period of time, while checking the inhibitor levels at a regular interval, and the doses can be increased almost as up to 100 to 200 units per kg if the inhibitor levels are not coming down. If at all we find that even with factors the inhibitor levels are not responding, we often have to resort to using other immunosuppressive measures. There have been studies where they've used IVIG, MMF, rituximab even, to bring down the immune tolerance, to bring up the immune tolerance of the patient.
I think this was more of the pre-emicizumab era when there were high Bethesda unit titers, so we had to resort to measures like immunosuppressant. But here, I think this is an option where there are low inhibitor titers and we don't have access to non-factor therapies easily. So there we can try ITI. Otherwise, where there are high titers, I think the more feasible option is to go on to emicizumab.
Absolutely, Dr. Ritika. So I think, Ritika, now we can summarize, with your findings on the, what is your experience of using emicizumab and,
Sure.
Forward to the next step.
I would request to allow me to share my screen. Yeah.
Echo team, can you please do the needful? Thank you.
Is my screen visible?
Yes, it's visible, but you'll have to wait.
I'll put it, yeah. So, oh, lost my screen. Just a second, I'm not able to see my. I'll just share again.
Not an issue.
Yeah. So I was asked to talk about our experience with emicizumab. So I would begin with the HERO study, which showed that 47% of patients with hemophilia report psychological and psychiatric conditions. So yes, the therapies are available, but still there are issues. Why the stress in these patients? The stress of repeated visits, stress of repeated pricks, stress of breakthrough bleeds, stress of unavailability of factors in times of need, and stress of missing school during childhood, stress of future uncertainties. So there's always a juggle for the physicians also between what is ideal and what is available. We all know primary prophylaxis is the best, but is it cost effective and practically feasible is the question. Even at our hospital, the Vijayawada Hospital for Children, which is one of the largest tertiary care pediatric super specialty hospital, we have the Department of Pediatric Hematology Oncology since early 1980s. Every year, around 5 to 10 severe hemophilias were diagnosed, and we were actually compelled to refer them to other hospitals for further management for their interest, for their best interest. Why? Because there were no factors available to us free of cost. The challenges were that factor therapy we knew is the backbone of therapy. Only select centers get factors from government, limited stock even at government centers, and many government centers are also not able to keep up with primary prophylaxis given the limited stock. So we kept thinking, what can we do for these patients? How can we help them with factors? How almost 30 newly diagnosed were referred to other centers. How could we have held them to our center only? How can we get factors for them to let them have a good quality of life as a primary prophylaxis? Is there a cost-effective way to do that? So yes, after lots and lots of thinking, persuading different CSRs and different NGOs to pitch in, our head of the department, Dr. Sangeeta ma'am, efforts, we took this step and we started a dedicated hemophilia and other bleeding disorder clinic since January 2024. Since then, we have diagnosed 8 patients with hemophilia, 6 with hemophilia A, 2 with hemophilia B, out of which 4 are continuing treatment with us, 4 hemophilia A and 2 hemophilia B. We started them on regular factor prophylaxis. So if you know Mumbai, these are the places where they hailed from: Vasai, Kalyan, Boisar, Kandivali. And if anyone knows Mumbai traffic, all of these places take around 3 hours to travel to Dadar. In January 2024, patients C and D were diagnosed and we started them on twice weekly prophylaxis. The next month itself, they came in irregular, their follow-ups were irregular, and because of the delay follow-up, patient C came with a muscular bleed. In the third month, both of them were not willing to come this often for factor therapy. So even this is the cost of giving primary prophylaxis for a 10 kg child. Twice a week factor therapy at 20 units per kg will cost around 20 to 30,000 per month. I'm talking about the standard half-life factors. Even if the cost is taken care of, these patients are not ready to come to hospital because it's logistically difficult, painful, financial burden to parents. They have to leave work, travel, school absences. So it's exactly been a year since we said yes to emicizumab. So it's the right time to talk about our experience here. We all know what emicizumab is. It's a bispecific antibody, comes in 4 different strengths, out of which these 30 mg and 60 mg are important for pediatric age group. It is to be stored between 2 to 8 degrees Celsius and is administered by the staff nurse here subcutaneously. So according to the Haven 4 trial, the 6 mg per kg dose was suggested every 4 weeks for 20, as in 6 mg per kg every 4 weeks was the suggested dose. And they realized that the ABRs were really low at this dose. But looking at our logistics and experience of other centers who've been treating hemophilia, we decided on this protocol. So we call all patients together one day. We divide and share doses amongst them, and the dose that we use is 2.5 to 3 mg per kg every 4 weeks. Company gives us emicizumab at the rate of around 45 to 48,000 for 3 vials. So it comes as a set of 3 vials to us of 30 mg each. And pharmacy, our own pharmacy provides each vial for around 16 to 17,000. So they give us individual vials easily. So approximate monthly cost for a 10 kg child falls to around 17,000, which is actually lesser than the SHL prophylaxis if you do this jugaad. So you can see the jugaad that we have done here. We divide the doses amongst the 4 kids, get the 4 vials, let them share them all and give it to them. So this way, these patients, these amongst these, there are two patients who were initially not ready to come for the factor therapy, and one of the patient's mother now actually takes charge of all the patients, calls them a day before the appointment, ensures that they all are coming together. Otherwise, ask for a review appointment a day or 2 day later. So this has strengthened their parent support group also. As far as ABRs is concerned, these four patients, there was zero ABR. There were zero complications faced. Compliance was 100% and patient comfort satisfaction was also 100%. So yes, we are prepared that if these kids come to us with a bleed, what are we going to do? So for a breakthrough bleed on a child with emicizumab, we first have to know their baseline inhibitor status. If they did not have inhibitors, then you can treat them with a factor therapy as you would treat other patients with a bleed. If they have inhibitors, then you have to give a bypassing agent like Novo7 or APCC. If you don't know the status, then better to treat with bypassing agents only. My take home points here would be we should know the pros and cons of all treatment strategies to advise the right strategy to the patient. We have to involve families in decision making, let them decide what is best for them, knowing all the pros and cons. Aid is all around, we just need to call for it. Aid in the form of financial help also. So apart from CSRs, NGOs, now in Maharashtra, we have the MJPJY scheme, which provides factors to them. So we've been taking help of that scheme also, specifically for patients who have inhibitors there. Even emicizumab can be availed through that scheme. So we need to know all of that. Share and care, if we share doses amongst other patients, it's easier to administer a cost-effective dose and it helps them form a patient support group. We must provide a patient information card to all of these patients, which should have their inhibitor status and everything mentioned. So if they come with a breakthrough bleed or if they land up somewhere else also, the treating doctor should know what is to be administered. And we need to formulate a plan beforehand only how to deal with a breakthrough bleed in them. Thank you so much.
Thanks, Dr. Ritika. That was really very encouraging for the resource-limited country to be practicing emicizumab prophylaxis. So from here, I'll just ask Dr. Neeta to move from resource limitation to what innovations we have very quickly in a couple of minutes. Neeta ma'am, please share your screen.
Thank you.
Yeah, thank you. So I'll just quickly wind up by saying that there are a lot of new products that have come in. So other than the factor VIII mimetics, which is emicizumab that was just discussed, which is a bispecific antibody, there is another bispecific antibody called Mimate, which is currently in phase 3 trials. There are centers which are recruiting in India as well. So basically, both of them have the same mechanism of action. It's just two companies that are doing it. Then there are agents called rebalancing agents. So rebalancing agents would include fitusiran, concizumab, which have been already licensed. So fitusiran license actually came in just last month. And this is an RNA inhibitor against antithrombin. So it's actually increasing your thrombotic potential. Concizumab is a monoclonal antibody against TFPI. So is marstacimab. Marstacimab is currently on trials. And then there is something called serpin-PC. Most of it is given subcutaneously. It is given like the dose which was described earlier by Dr. Ritika. So it could be 2 weekly to 4 weekly in the case of emicizumab. In Mimate, it is once. You could give it once in 4 weeks. Fitusiran, you could give it even once in 8 weeks as well. And these rebalancing agents can be given in pan-hemophilia scenarios, which is A or B with or without inhibitors. Whereas emicizumab is given only, emicizumab Mimate would be only for A. So this is the product which we show, and these are the Haven trials. I think the residents in the call, you should look up what is Haven trial. These are the remarkable studies which have been done. So if you look at use of emicizumab against the standard bypassing agent product, it is actually very cost effective, especially if you use it in a low dose scenario. And when you have limited access, you would keep your product for patients who are difficult to treat, like multiple arthropathy, difficult bleeds, pseudotumors, etc. And so these are the Indian studies that have come out, and there is paper from NIH also, which looks at inhibitor naive patients. So it can be given in inhibitor naive as well as inhibitor positive patients. Only thing is, while you are on the product, you cannot use APCC as a bypassing agent. So if you have a breakthrough bleed, then you should use factor 7, which is there as a breakthrough bleed treatment. And finally, gene therapy is almost there. There are studies which are currently in C1C Vellore also has a has a project which is looking at a lentiviral vector-based therapy. So the entire products which so far have come, which are actually look at in vivo gene therapy. So basically, you don't need to take out cells. So unlike thalassemia or immunodeficiencies, where you have to take the stem cells out, you have to modify it outside. It's like an autologous transplant for the patient. You give busulfan-based chemotherapy and then give it back. So that is not necessary for hemophilia. It is generally all the studies which have been done have looked at AAV vector, and you can just infuse it like an infusion, and it goes to the liver. These are hepatotropic viruses, AAV, and it integrates with the the cells, the genome of it, and starts producing factor VIII. So these are the multiple products, multiple companies are there. Some of them have been approved for use. It's frightfully expensive. So in a scenario of having very good non-factor replacement therapy, very good extended half-life treatment, often we may not have to even resort to a curative measure. Patients are really happy. So surveys have actually shown that patients often prefer a product which they know and they're comfortable with rather than opting for something which is unknown. So these are the measuring tools again that you would need to know. So hemophilia joint health score, the activities list for functional assessment, FISH, which is developed by CMC Vellore, again for functional assessment, and quality of life scores as well as important when you're treating a patient. So I'll stop here, Dr. Vinay.
Thank you, Neeta ma'am. Very nice summary of the recent innovatives, couple of slides, which I have put it in our group as well. A lot to read about it, and we see how we evolve from here. Dr. Bipin, closing comments or one or two cases if you have to discuss and enlighten about things.
Yeah, thank you. So I'll just share my slides again. Yeah. Is it visible?
Yes, sir.
Okay. So I just have a few cases. So based on today's discussion, which is inhibitors, lab assays. So these are just 4 or 5 interesting cases. So this was one case which is sent from a camp, like the hemophilia camp, where we found both the factors low and the Bethesda was positive. So what do we do in this case? The LA we did, it was strongly positive. So it was indicating towards a strong antiphospholipid antibody related deficiency. But here the inhibitors were for factor 8 and 9, both we were getting positive. So we looked into the family, and this was a family of hemophilia A. So what we did was we just diluted out the samples to much higher dilution. So because it was lupus related, the genuine deficiency, which was the factor 8 deficiency, it remained deficient, whereas the factor 9, which was falsely getting shown as deficiency on a one-stage assay, corrected by itself. So what was happening here, since the APDT reagent has phospholipids, those are mopped up by the antiphospholipid antibodies, and you get a prolongation on a one-stage assay. So which corrected, and we could give a proper diagnosis in this case. So this is the second case, again a 45-year-old lady with cardiomyopathy. So there was no bleeding, but then she had a APDT which was done on low phospholipid reagent, which was very prolonged with no correction. Factor 8 and 9 were normal. So here, when we use the high phospholipid containing reagent, it showed correction, which again this case was a case of strong LA positive. Now this is again interesting case where this lady was getting her APDT totally different from 2 different labs. So it was 105 in one and 32 in other, and she had no bleeding history at all. But consistently this was the case. Her factor levels were normal. So when this came to us, what we did was we did a prolonged incubation of the APDT time. So instead of 3 minutes, we incubated for 15 minutes, and we got a correction there. So this indicated a contact factor deficiency. So in one of the labs, the APDT reagent they were using, probably it was very, very sensitive, and the other one was not. So it showed differences in the APDT time. So we just gave increased time with the APDT reagent and the deficiency, it was kind of got a correction. This was a 6-year-old boy who was mild bleeder, not a very severe bleeder. There is no history of spontaneous bleeding, and his APDT was surprisingly 99, but his factor VIII was 6.1, which was in the mild range, which correlated with his clinical manifestation, which was also mild. His von Willebrand antigen was normal, platelet count normal, everything normal. So somehow this was not correlating with the APDT of 99. We did a LA which was weak positive. Again, this was not correlating. A weak positive LA should not give a APDT of 99. So we decided to do other factors, and coincidentally we found him to have factor 12 less than 1%. So as we know, factor 12 deficiency does not contribute to bleeding. So his bleeding manifestations remained mild, though his APDT was deranged, and that was because of his coincidental factor 12 deficiency also. So it was kind of a rare occurrence. Now, these two cases, these were two girls who had type 3 von Willebrand disease, congenital type 3 von Willebrand disease. And now they presented with bleeds, and when they were treated, they did not respond optimally. So in these cases, Dr. Chandrakala suspected that they may have developed inhibitors to von Willebrand. Now, we do not have a standardized assay to pick anti-von Willebrand factor inhibitors. So what we decided in these two cases, since we had two cases, we decided to adopt the Bethesda assay and to use it to pick up the anti-VWF antibodies and whether we are able to quantitate them. So we modified this assay, and we could successfully pick up the inhibitor titer in these two cases using the Bethesda assay. So one of these patients, he had a Bethesda assay inhibitor titer of 217.6 Bethesda units per ml, and the other one had 2.8 Bethesda units per ml. So it also correlated with their in the clinical history and everything. So this was the second case, which the antigen on mixing was 24, and here in the first case it was on mixing also, it was not correcting at all. She had a very high titer as compared to the second case. So though it is very rare, but we do get once in a while inhibitors to von Willebrand disease as well. So that should be kept in mind, and we could publish these cases. So that's all. These were my cases. Since we had short time, I did not put too many cases.
Thank you, Dr. Bipin. I think I'm glad we didn't miss out on these cases because they were really interesting. I believe we've had such an interesting session that we can go on, and we would probably not realize how much time we've been here. So thank you everybody for being here. And before we close, I would like to hand over to Dr. Manas Kalra. Dr. Manas, are you there?
Hi, Shruti. I'm just trying to see if I can share something from my desktop. There was something very interesting, and I thought, I'll just show to everyone. And can you see it?
Yes, sir.
Okay. So this is a hemophilia child who is on extended half-life factor. Can you see it?
Yes.
Yeah. So, just on this hemophilia day, showing that, children with hemophilia can actually do this. He's in Switzerland enjoying skiing. He has severe hemophilia A on extended half-life factor, doing very well. So, it's all about hard work, regular factors, good care. And as all of you have demonstrated that, multidisciplinary care can bring in excellent outcomes for children with hemophilia. Let's hope that, the PHO community will work for children with hemophilia and have excellent outcome for these patients. That's it. Thank you so much.
Before we close, I would request to, reach out to all the students. We are looking for participants from various centers who want to participate in our PHO activities. For the next month, we'll be taking up some cases on hemoglobinopathies because we have the International Thalassemia Day coming up. So if any one of you is interested in presenting a case that you think is something that should be shared with our community, please reach out to me, Manas, or Vinay, and we would try to have as many people involved as possible. So anyone who's interested, please drop a message, and we would love to have you on our panel next month. Thank you, everybody, and I'm extremely grateful to all the students who joined today and stayed back for more than almost 1 hour 20 minutes. And thanks a lot to all our faculty members, Dr. Bipin, Dr. Ritika, Dr. Neeta, and our fellows Sudipto and Shreyasi for presenting these cases. Thank you.
Thank you so much. Thank you,
very
everyone.
much.
Thank you.
Thank you so much. Thank you.